Well, good morning, everybody. Wonderful to see you here. I'll go ahead and get started with announcements and introductions as folks filter in. Welcome to today's Medical Grand Rounds. And today is one of our talks in our series on high-value care. Just as a reminder, in part, this series is a call to the medical profession to reduce waste and unnecessary care so that we can more efficiently channel our energy and our resources into those treatments and therapies and diagnostics, whether they be new and innovative or tried and true, that really do add value for our patients. Today, I am truly delighted to introduce our speaker, Dr. Otis Brouwely. He's the Chief Medical Officer for the American Cancer Society. And in this role, he is responsible for promoting the goals of cancer prevention, early detection, and quality treatment through cancer research and education. He earned his medical degree at Pritzker School of Medicine at University of Chicago, did his residency at University Hospital of Cleveland, and his fellowship at the National Cancer Institute. Dr. Brouwely is a professor of hematology oncology, medicine, and epidemiology at Emory University, and was the prior director of the Georgia Cancer Center for Excellence at Grady Memorial Hospital in Atlanta. Dr. Brouwely has filled a variety of capacities at the National Cancer Institute, including the assistant director. He is a master of the American College of Physicians and has received numerous awards, including one of America's top doctors for cancer. He has been a true champion of public service, and it is particularly in that vein that I am delighted to host him here today. Dr. Brouwely.
Thank you. Thank you. It's wonderful to be here, and thank you, Dr. Lecher, for helping me out so much here. I want to talk over the next couple of minutes about what's going on in oncology, what's going on in the economy. But first, we'll talk about cancer control in the 21st century and how it relates to the economy and other things. In terms of disclosures, I work for the American Cancer Society and Emory University. I also have a gig at CNN. They keep me on staff to make Sanjay Gupta look good. It's the contrast between the two of us makes him look even prettier, you know. And I consult for the federal government. I also wrote a book a couple of years ago. I'm not here to talk about the book, but it still should disclose it. Cancer control involves basic and applied research in behavioral, social, and population sciences to create interventions to reduce suffering and death from cancer, essentially. And that's the National Cancer Institute definition. Now we're going to talk about costs of health care, 21st century definition of cancer, and how the definition of cancer is really changing. I'll talk about some of the trends in mortality, especially some of the geographic patterns in mortality, and talk about the disparities that exist in the United States. And then I'm going to make a plea that we start practicing more preventive medicine, because I think that's going to get us out of all of this. Now, this is really 3 or 4 very different talks, but they all end up having one common theme, and that is we need to practice evidence-based medicine, and that's going to be the way to get ourselves out of some of these problems. First, let's talk about the cost of healthcare. In 2011, we spent $2.7 trillion on healthcare in the United States. In 2011, we spent $1.1 trillion on food, but we spent $2.7 trillion on healthcare. And healthcare was 17.7% of our economy. For every dollar spent, 17.7 cents was spent on healthcare. The United States gross domestic product is $14.5 trillion. Germany is at 3.28. Japan is at 5.46. We spent more money on healthcare than the entire economy of France in 2011. If American healthcare were its own economy, it would be the 5th largest economy in the world. Only Germany, Japan, China, and the United States would be larger than the U.S. healthcare economy. When we look at spending on a per capita basis or percent of GDP, we have this. We have the United States at 17.7%, of its economy, or $8,500 per man, woman, and child, and this is back in 2013 or so. These are what other countries spend. You can see the most expensive countries in the world are Norway and Switzerland, other than the United States. We spend an awful lot on health care on a per-person basis, and part of my message is we don't get what we pay for. When you look at life expectancy versus what we spend per person on health care, you can see here's the United States, and we spend an awful lot. Here's all the other countries we generally like to compare ourselves to. They spend a lot less money, and they have longer health care, longer life expectancy. Again, this is not a great value proposition. Looking at Canada, because everybody likes to criticize the Canadian healthcare system, Switzerland, which is one of the most expensive systems other than the United States, and the United States, we tend not to do well. We have worse infant mortality. We have worse white male life expectancy. And there's the per capita costs again for 2011 or so, and then percentage of the GDP. Notice the other countries are spending 11.5% or less on their GDP. And when we look at trends in spending, everybody's per capita cost for healthcare is going up, but the United States is going up faster than anybody else. This is from 1980 onward, looking at a number of different countries. Everybody's going up, but we're going up faster. By the way, one of the most striking trends that I've seen so far is a paper that was published not too long ago by some family practice docs, and all they did was they looked at the last 30 years, and they just took the lines for the last 30 years for cost of health care for a family in terms of a health insurance policy, and they looked at median family income. And if you just extrapolate the lines from the last 30 years out for the next 30 years, it's 2035 where the median cost of a health insurance plan for the average family in the United States equals the average family income in the United States. It's only 18 years from now. And by the way, median family income in the United States is currently $47,000, and the average cost of a health care plan for a family in the United States is now $19,000 a year. Told you about 2011. In 2015, we spent $3.2 trillion on health care. That $3.2 trillion now amounts to $10,000 per man, woman, and child, and it's 17.8% of our gross domestic product. For people who are interested, of the $3.2 trillion, you can see the breakdown for Medicare and the breakdown for Medicaid. They're both combined roughly about a third of health care is already spent by government. Private insurance is another. Actually, it's more than a third because VA is not included in that 1/3 when I add Medicare and Medicaid. Private insurance is again about a third. Out-of-pocket spending is about $340 billion. When we look at what the costs are, hospital costs are about a third of that $3.2 trillion. Doctor costs are only about 15%, but they've gone up. They're going up at about 6% per year right now. Prescription drugs are the ones that are actually going up outrageously. Prescription drug costs really have a bullet next to them. Of course, I'm an oncologist. I like to give drugs that cost $14,000 a month nowadays. The average cost of a family health care policy, this was 2016, it's over $19,000 this year. If we were Switzerland, the second most expensive country, the average cost of a family health policy would be less than $12,000, between $11,000 and $12,000. We would have higher productivity, and our employers would actually be able to hire more employees. That was put there just to key me to point out that the cost of health care in the United States is actually suppressing the American economy right now. If employers didn't have high health insurance costs, they would actually be employing more employees, and costs are going up. So we really are going to crush the American economy. Now, again, my answer to that is we need to actually start practicing evidence-based medicine and do the things that actually matter, worry about value. I would point out to you, as an oncologist who prescribes those $14,000 a month medicines, the American Society for Clinical Oncology, our own society, actually has looked at FDA-approved cancer drugs over the last 10 years. And ASCO, the American Society for Clinical Oncology, has issued a statement saying 19% of those drugs actually were approved because of a clinically significant endpoint. That means 81% of those drugs were FDA approved because they increased median survival by 2 months or 3 months. Of course, my favorite of all time was Tarceva for pancreatic cancer. It only costs $50,000 a year, although most patients don't take it for an entire year, unfortunately. Tarceva was FDA approved because in a prospective randomized trial, it increased median survival by 11 days. Yeah, one of my infectious disease friends sent me a stopwatch for my next clinical trial. By the way, I'm not picking on the FDA. They have to approve the drugs if they're safe, effective, and equivalent to drugs already on the market. They don't even have to be better than drugs that are already on the market. That's, of course, how Nexium got FDA approved at $180 a month. It was compared to Prilosec, which generically cost $8 a month. Of course, those of you who know GI medicine know that the active ingredient in Nexium is the active ingredient in Prilosec. Now, redefining cancer. Cancer, you guys all know this, is uncontrolled cell growth. I just put this in because there's some nice pictures here. Prophase, metaphase, anaphase, and telophase, and I stayed up all night memorizing those terms. Again, mitosis and uncontrolled cell growth, and some cancerous cells, of course, can spread throughout the body, as you can see from these bone scans. We have been writing on a 19th century definition of cancer since the mid-1850s when this guy, Rudolf Ludwig Karl Virchow. This is Virchow with Virchow's note. Most of us in medical school don't actually appreciate his true contribution. He was a Renaissance man in many respects. He was one of the first people to actually realize that poor people don't do as well from a healthcare perspective as do wealthy people, that the environment can actually cause many diseases. But the really important thing he did for a guy who does cancer is he defined what cancer was using a microscope. He and his students at the University of Berlin in the 1840s and 1850s did a series of autopsies on people who died of cancer. He would take someone who clearly had a breast cancer, it had eroded through their breast and there was an open sore, and then they had died, and he did the autopsy to show that it spread to the liver, it spread to the lung, it spread to bone, it spread to brain. He also, very importantly, worked out for the pathologist that you cut the tissue very thinly, mount it on a glass slide, and you stain it with, he used carmine first. Later, he met a Dr. Bayer who showed him what H&E was, Bayer of the aspirin. But this is an H&E stain of an adenocarcinoma. And Virchow, who also was a marvelous artist, actually drew pictures of what he saw under the microscope and said, this is an adenocarcinoma. He came up with the words adeno and carcinoma. He's even the guy who knew Greek and knew that Lu stands for white and chemia for cell, and he's the guy who named leukemia. But anyway, he defined what cancer is, and for the next 160 some odd years, if a pathologist saw this, the pathologist said, the patient has cancer. Now, that was in 1853, and all of his patients obviously died of cancer. He actually did autopsies on them. Keep in mind, we had the X-ray invented in the 1890s, the mammogram really came forth in the 1950s and 60s, the ultrasound in the 60s, the CT scanner in the 70s, and the MRI in the 1980s, and then stereotactic biopsy methods have been perfected this century. So now I can find a lesion in a woman's breast the size of a pea, and I can actually get a needle into it. And I can send that biopsy to a pathologist, and that pathologist is going to actually stain it in the same methods that Virchow stained them late in his career, and the pathologist will then look at it and say the patient has cancer. This is actually a mammogram of a fairly large breast cancer. We find things that are much smaller than this nowadays. Now, the mistake is that small pea-sized lesion wasn't genomically programmed to grow, to spread, and to kill. Is that small pea-sized lesion destined to become this? This is a bone scan of a woman with widely metastatic breast cancer. And the answer, the epidemiologists, in looking at the population and looking at incidence rates and looking at mortality rates, we can actually tell you that a certain proportion of these small tumors are not genomically programmed to grow, spread, and kill. We call those overdiagnosis cancers. Right now, it's looking as if 15 to 20% of screen-detected lung cancers, 20 to 25% of screen-detected breast cancers, 40%, perhaps even more, of ultrasound-detected thyroid cancers, and about half of all prostate cancers, perhaps more. They were never going to spread, and they were never going to kill, and we can cure these people, but they don't need to be cured. We have totally redefined cancer for the 21st century. We're getting better, though. We're actually starting to look at genomes and genomics, and we're starting to appreciate varying biologic behaviors of cancer. When I graduated from medical school in 1985, we didn't appreciate that some cancers grow slow and some cancers grow fast. The pathologists did, but we didn't really listen to them. Now, we're starting to look at these genomes and new molecular targets, and we have tests for breast cancer like MammaPrint or Oncotype DX, and they exist for other diseases as well. And we're starting to, Oncotype DX is actually the easiest to define. It's 21 different genes. And you ask the first question, is the gene turned on or turned off, yes or no? If the gene is turned on, is it overexpressed, yes or no? And you create these profiles and with these answers. And we're starting to say breast cancers with this profile seem to be the more benignish breast cancers that are less likely to grow and progress. Breast cancers with this profile, those are the ones that actually kill people. And we're actually able to ascribe a number. Realize there's a lot of gray here. You know, it's not just the ones that don't progress and the ones that do grow very quickly. There's a lot of in between. And unfortunately, there's some tumors that will kill in one person but won't kill in another because of that person's immune system or because of that person's age or other comorbidities. So cancer, all of a sudden in the last 10, 15 years, has stopped being just what's on the slide. It's what's on the slide and what the genomic tests are. Right now, about 35% of Americans who are diagnosed with cancer are getting genomic profiling. Really, by 2025, to not get genomic profiling on a diagnosed cancer will be considered a malpractice. This is just looking at lung cancer. You know, when I graduated from medical school 32 years ago, we had two kinds of lung cancer that were important, small cell, and I'm still trying to figure out why we call it non-small cell lung cancer. When I graduated from fellowship in the non-small cell lung cancer, squamous versus adeno was important because we had certain drugs that we gave to squamous and certain drugs that we gave to adeno. Now, all of a sudden, when we look at lung cancer, I want to know, does it have a BRAF mutation? Is HER2 amplified? That's HER2 from breast cancer. And yes, we are now treating some lung cancers with Herceptin, the drug that was FDA approved for the treatment of breast cancer 20 years ago, that was actually developed to treat HER2 receptors on neuroblastoma, by the way. We're looking at, do they have ALK mutations? ALK-mutated lung cancers, I don't see, yeah, ALK-mutated lung cancers, crizotinib and other drugs are actually very appropriate. Non-small cell lung cancer, by the way, genomically is now considered at least 80 different cancers. It was 2 when I finished my fellowship in 1991. By the way, I went into oncology because everything was simple. You couldn't do anything. Now let's talk about trends in mortality and where things are going. You know, I'm the chief medical officer of the largest health charity in the world, and people come and ask me, how are we doing in the war on cancer? I hate that phrase, war on cancer, by the way. Ted Kennedy gave us that phrase when Richard Nixon signed the National Cancer Act. He said, Richard Nixon is declaring war on cancer. I hate that phrase. But anyway, we're stuck with it. The answer is that I'm an epidemiologist, so you bear with me a few number slides here. In 1900, the death rate from cancer was 64 deaths for every 100 Americans. And this is age adjusted to the 2000 census. Don't worry about that. That just means we take away the fact the population's getting older, okay? This is not an increase because there's more older people around nowadays. In 1991, we'd gone from 64 to 215 per 100,000. Over the last 24, 25 years, we've had a 25% decrease in death rate. Going from here to here is good. Going from here to here, still a lot of explaining to do. A lot of it is smoking and other things. We'll get to that in a little bit. But a 25% decrease is pretty good since 1991. It's due primarily, number one, to prevention of cancer, and we'll talk about that in a little bit. I'll not leave you hanging. It's the fact that a lot of people stop smoking. Improvements in treatment, increased awareness of cancer, more effective screening and effective use of screening. I point that out because I'm not talking about screening today, but there's a lot of waste in screening, a lot of wasted resources with very ineffective use of screening. Now, that 25% decline over 23 or 25 years is a wonderful thing. It means that 2.1 million Americans did not die a cancer death. But it's also a shameful thing in that we were the 31st country in the world to actually have a 20% decline in our cancer death rate. Romania had a 20% decline in the cancer death rate before the United States. It's not something to be proud of. Now, what if we applied what we already know about cancer? Because you see, that's the problem. We're not applying this incredibly expensive healthcare system we have. We're not applying what we already know. Well, I work with some wonderful epidemiologists who can manipulate the numbers every which way. This is one manipulation I think is really important. There's going to be about 596,000 people who are going to die from cancer in the United States this year. It's a fact that people who have a college degree are less likely to die than people who don't. How many people would die in the United States if every American had the death rate of Americans with a college degree? The answer is 75% lower than what's going to happen this year. 148,000 people would not die if all Americans had the death rate of Americans with a college degree. That's not new biology. That's not new science. That's just applying what we already know, and that's a new definition of disparities. That's the realization that people who don't have a college degree have disparities in preventive medicine as well as treatment and other things compared to Americans who have a college degree. Now let's look at colon cancer. Colorectal cancer, about 96,000 are going to develop colon cancer this year. About 40,000 will develop rectal cancer. Dying from colon and rectal cancer, we don't have a death rate for colon, a death number for rectal. Dying from colon and rectal, it's about 50,000. Significant cancer. This is looking at black men. Black men on top in blue, white men in red, black women in green, white women in purple, and we're going from 1975 all the way through to 2014 here. And the purpose of this slide is to show you in the 1970s there were no real black-white disparities in death from colorectal cancer. It was only in around 1980 or so when we actually started having screening, better ways of treatment, and so forth. That's when the disparity in blacks and whites started happening. The scissoring here, the separation in death rate for men and for women. And actually, the disparity is greater today than it's ever been. This is in colorectal cancer. This is looking at, for people who are interested in health insurance, this is not looking at race, this is looking at insurance versus non-insurance. And I typically don't like to show a lot of survival slides because, quite honestly, 85% of the time I see somebody talk about cancer survival, they're talking about it in the wrong way. So this is one of the 15% of the times where we're using survival in the correct way of analysis. In red here is stage 1 disease, or Dukes A disease. In blue is stage 2, or Dukes B disease, the more advanced disease. The solid lines are insured Americans, and the dotted lines are uninsured Americans. And this is just to show that the 60-month or 5-year survival of uninsured stage 1 patients is less than insured stage 2 patients. If you're going to get colon cancer in the United States and your goal is to be alive in 5 years, have insurance. You are better off having the more advanced colon cancer with insurance than the less advanced colon cancer without insurance. Insurance matters as to whether you're going to be alive in 5 years. This is redefining disparities. This is to show that, now, colon cancer rates were actually, death rates were actually higher in Massachusetts and New York in the 1990, 1980 period compared to Mississippi and Alabama. But once we learned how to diagnose and treat colon cancer, this is to show the decline in death rate in Massachusetts and New York compared to the decline in Mississippi and the lack thereof, the decline in Alabama and the lack thereof in Mississippi. You see, we are now starting to develop disparities by what state people live in. This is not black-white. This is not looking at whether someone is insured or not insured. This is actually looking at whether someone is educated or not educated, because there's more college-educated and less high school diploma people. There's more college-educated in Massachusetts and New York and less people who've even gotten to high school in Mississippi and Alabama. So this is socioeconomic status. Now let's look at breast cancer. 269,000 will be diagnosed. By the way, about 2,000 of them will be men. About 31,000 will be black. 41,000 will die. About 6,300 will be black of those dying. This is breast cancer in the United States. Late 1980s, we start having this drop. 39% decrease in age-adjusted mortality from 1990 to 2014. 25% drop in all cancers, 39% in breast cancer. That's good. Now, incidence, black, white. Black women used to have a lower incidence rate in the 1970s and 80s and 90s. The incidence for black women has gotten to be the same as the incidence for white women only recently for a couple of reasons. We'll get into that in a bit. This is mortality. Black women in red, white women in blue. There was no difference in mortality in the 1970s. Early 1980s, the era of screening and treating, and all of a sudden we actually have a rise first time in black women, and now we have a greater disparity than ever before in death rate. That's a 28 black women for every 100,000 dying from breast cancer compared to about 20 per 100,000 for white women. In the early 1990s, we realized that Asian people existed and Native American people existed, and Hispanic people existed, and we started actually counting their death rates. There are no recorded death rates for these folks before 1990. They have lower death rates. The noise here in Native Americans is because there's so few Native Americans. They make up less than 1% of the population. The decline in death rate, and there is a decline here for black women, a decline for white women. The decline is 23% in black women, 42% in white women. That's that 39% again. These are the states that have not had a 10% decline. A woman in the United States has a 60% chance of dying from breast cancer compared to a woman in the United States for 1988. That's the US as a whole. In these states, the decline is less than 10%, so their risk is 90% of what it used to be. This is not a black-white issue, especially when you look at places like Utah, Wyoming, South Dakota. This is a rural versus urban issue. This is a rich-poor issue. This is a quality of medical care issue. This is an access to medical care issue. This in the most expensive country in the world for health care. And we can't get good care to women who live in Oklahoma, Missouri, or Arkansas. In my own city of Atlanta, Mary Jo Lund was one of my fellows. She actually looked at the SEER registry and noted that 7.5% of the black women who heard all those advertisements about mammography and went out and got one and was diagnosed with a localized curable breast cancer, 7.5% didn't get treatment within the first year of diagnosis. They had enough access to health care that they could get a biopsy, but they didn't get treatment within 1 year of diagnosis. 2% of white women in Atlanta fall into that category. And they all have the same thing in common, and that is they have socioeconomic issues that prevent them from getting good health care. See, we have the most expensive healthcare system in the world, but a substantial number of American women are unable to get optimal health care. And provision of adequate care, that's a logistical issue. This isn't new science. This is just giving the old science that we already have to people. This is a complicated slide, but let's try to work through it. I hope you can see the numbers here. I'll help you out. The lightest numbers are about 19 deaths per 100,000. The darkest are 24 deaths per 100,000. This is to show that white women, non-Hispanic white women who live in these states with the very light colors do much better for breast cancer than the women who live in the darkest states. Oregon does pretty well, kind of in the middle here, but it's not Illinois, Ohio, West Virginia, Oklahoma. This is the same type of thing. The numbers differ here. We got 20 in the light and 31 in the darkest here. This is black women in the United States. These are the states where there's not enough black women to figure this out. But what I want to point out is we used to talk about, I showed you that disparity of black women in the United States as a whole. There's no black-white disparity in 7 states in the United States. As a matter of fact, black women who live in Massachusetts have a lower death rate than white women. It's the only place in the United States where it's actually better to be black. This is not new biology. It's not new science. This is lack of people getting the old science. And there's been a lot of talk about triple negative disease, especially in black women. We're going to tackle that when we talk about cause of disease here. 24% of black women have triple negative disease compared to about 12% of white women diagnosed with breast cancer. Differences are obesity, dietary differences, reproductive patterns. We found out that a risk factor for triple negative disease is having more kids, having them earlier. Interestingly, not having a child or delaying childbirth until after the age of 30 is a risk factor for estrogen receptor positive disease. So when we ask in the United States, why do black women tend to have more triple negative disease? One of the questions we should be asking is why do white women tend to have more estrogen receptor positive disease or non-triple negative disease? And the answer is people who go to college, people who get an education, people who have a career, they tend to put off having children or never have children, and that increases the risk of the good kind of breast cancer. Whereas having kids when you're in your teen years and having many kids, and especially having many kids and not breastfeeding, increases risk of the bad breast cancer. There's also social deprivation studies in Europe, especially, and the US, that show that estrogen receptor negative disease is more common in poorer women. Part of that, by the way, is, I'm going to give part of the punchline out here. We have data to show that a girl who is born and who is fed a high carbohydrate, high calorie diet, who starts menstruating early because she gains a lot of weight from birth, that child, when she's in her 40s, 50s, and 60s, is at higher risk for estrogen receptor negative, triple negative breast cancer, if she gets breast cancer. A girl who is born middle class and fed a high protein diet and gains weight slowly and starts menstruating later in her life, she, even though it might be just an average of 2 years later, that child is actually at lower risk for the estrogen receptor negative breast cancer later on in life. It's all having to do with poverty. The Scots actually did the studies better than anybody else because they have great deprivation indices. This is obesity over time in the United States for non-Hispanic black women, non-Hispanic whites here, and non-Hispanic black men here. There's a huge obesity problem among black women in the United States, and it's gotten worse over time. That reflects in, by the way, obesity reflects in we don't treat women with breast cancer who are obese as well. We as doctors are afraid to dose them with chemotherapy when chemotherapy is called for. And actually, how can we provide adequate high-quality care, especially preventative services, to people who don't often get the care is, I think, one of the most important questions that we can ask right now. Now, reasons for the disparity in black-white differences are disparities in quality of mammography, follow-up of abnormal findings, treatment, and other things, and the aggressive tumor characteristics. But so there are these differences, but blacks are less likely than whites, Hispanics are less likely than whites to get adequate care. And by the way, 20% of white women in the United States who get breast cancer get inadequate breast cancer care. In this country that spends more money on health care than anybody else, 20% of white women don't get good breast cancer care. I told you about that. Our healthcare system is so heavily focused on treatment, making a diagnosis, and making money, and not enough focused on prevention. Let me just give you one quick example of how that gets into our psyche. I spend a lot of time in Europe. If you have a medical student here in Oregon or anywhere in the United States who's with an attending physician who sees a patient for newly diagnosed moderate hypertension, that attending physician may prescribe lisinopril to the patient. And he may ask the medical student, or she may ask the medical student, why am I prescribing lisinopril? And the medical student will say, you're prescribing lisinopril to treat the high blood pressure. If you go to France and you have the same scenario, and the attending physician asks the medical student, why am I prescribing lisinopril? The medical student is saying, you're prescribing it to lower the patient's risk of stroke, heart disease, and kidney disease. In Europe, they're thinking about preventing disease. In the United States, we're thinking about treating disease. And this is one of the reasons why we spend so much money. We need to start thinking about evidence-based medicine, number one, and we need to start thinking about how do we prevent the diabetes, how do we prevent the cardiac disease, how do we prevent the cancer. Now, I'm going to end very quickly by talking about preventing cancer. Number one cause of cancer is still combustibles, smoking, 33% or so. Unbeknownst to a lot of people, the data over the last 20 years has shown us that the number two cause of cancer, soon to be the number one cause of cancer, is obesity, too many calories, the euphemism is poor nutrition, and physical inactivity. This is where the fat guy talks to you about obesity and cancer. Number two cause of cancer. As smoking rates are going down, it's going to become number one. Viruses, genetics, alcohol, radiation, all those other good things. This is tough for the young people to realize, but those of us with gray hair can still remember the 1960s and can vouch that this is true. In 1955, 55% of adult men in the United States smoked cigarettes. In 1965, 35% of adult women smoked cigarettes. And it's gone down dramatically over the last 50 years. These numbers are actually 2010. This is actually high now. We're at probably 17, 18% of men, maybe 15% of women. We still have a problem among Native Americans, still have a problem among Americans who live below the poverty level. This is the United States for smoking in 2013. The dark states are the states where we have a real problem. The lighter states have very low smoking rates. I should point out, California is at about 10% who smoke tobacco. Within the next 2 decades, this is going to be a real problem for cancer. This is obesity in the United States, 15% in 1970, 35% today. These are other countries. They have a problem, but it's not nearly the problem that we have. Looking at race and ethnicity, huge problem for black women. Actually, this is 2010. There's 2015 data that suggests 60% of black women are now obese. Cancer control, this is the last slide. We need to work on avoidance of carcinogens. We need to work on weight. We need to screen wisely. And we need to focus on provision of adequate care. Evidence-based adequate care is where we need to go. The science is picking up fast. We're changing their definitions of cancer. We're actually figuring out that some of the folks that we used to treat didn't need to be treated. In the future, we're going to actually have a large number of people who are diagnosed with cancer through especially PSA screening, but also mammography. It's coming very quickly, who we're going to watch instead of give some of these very expensive treatments to. And so I've tried to link the cost of cancer, some of our new science, and some of the things that are going on in outcomes and in treatment all together, and hopefully tried to make an appeal for you to follow the evidence and try to focus a little bit more on prevention of cancer. Thank you. Do we have time for?
Yeah, we certainly have some time for questions.
Yes, ma'am.
Thank you so much for your lecture. It was fantastic, and
Hey.
I learned quite a bit from it. You talked about in Massachusetts,
Yeah.
it's the one place in the country where to be a black woman, you actually do better. And I'm wondering if you think that this is related to the healthcare reform that took place in Massachusetts in 2006, and it took 459,000 people off the
It definitely did. There were things about Massachusetts that were better before that, and actually those things probably caused that healthcare reform to occur. But we've got definite data to show that, for example, in states that have expanded Medicaid, we already have more women who have been diagnosed with cervical cancer who are being treated for cervical cancer with curative intent. We've got more people who colorectal cancer death rates have actually gone down in the states that have expanded Medicaid already. And that's very early. So we're actually creating a new disparity between the states that have expanded Medicaid and the states that have not. And when I talk to my friends who do other than cancer, who do asthma, who do diabetes, amputation rates and stroke rates are actually going down as well. So that's the part of, I used to hate to call it Obamacare, but he said it's okay to call it Obamacare because he cares and they don't. That's the part of Obamacare that's not getting out, is that we actually do have some definite improvements in the numbers already. And I obviously think the answer is to fix Obamacare rather than to get rid of it. Yes, sir?
Other than prostate cancer, give me an example of a cancer that you would find that wouldn't require treatment. I can't
Right now,
having one.
well, actually the most thyroid. Thyroid cancer, the protocols are to observe a number of thyroid cancers. Some of the kidney cancers small kidney cancers that are being found on CT scan nowadays are being observed. The most dramatic issue actually in screening is neuroblastoma in children. There's a urine test called vanilla mandelic acid that was used in screening in eastern Canada. And what they noticed was that the neuroblastoma incidence rate in kids in Quebec went out the roof compared to kids in Ontario. But the mortality rate stayed roughly the same. And that led us to realize that there's a bunch of kids who develop neuroblastoma at about the age of 6 months to 1 year. And if they just leave them alone over the next year or so, the neuroblastoma goes away. But if we do the screening test, we can find them and cure them.
But what ones, how do you decide which ones will go away and which ones won't?
In breast cancer, especially in DCIS, we've got pretty good data to show that we're going to be able to very soon have these genomic tests, Oncotype DX and MammaPrint, within the next 5 years. There's already clinical trials where this is happening, where the woman is told, you have DCIS, given your MammaPrint results or given your Oncotype DX results, we would like you to go into this trial where we watch this cancer very carefully. And those trials, if they turn out to be what I think they are, we're going to be watching more and more of these cancers.
But you say a renal carcinoma, if you watch it and it's 2.5 centimeters on the CAT scan, 2.5 centimeters or below by surgery has a survival rate of 10 years or more.
Many of them have a great survival.
2.5 centimeters, that survival rate decreases tremendously
Yeah.
without much
Yeah.
treatment for it of significance.
The protocol at many of the leading hospitals nowadays is, and they're finding more and more of these very small 1 centimeter tumors that appear to be malignant renal cancers, or even smaller. They're finding these things because there's so much CT scanning going on for lung cancer screening, CTs of the abdomen for other various things. They're finding a lot of these things, and the protocol at a number of major hospitals is, we're going to watch it. If it starts growing and it gets to be 2 centimeters, then we'll take it out. But if it's 1 centimeter and it appears to be malignant, especially if it's in someone who's over 65 years old, we're going to watch it. Same is very true in thyroid cancer. In bladder cancer, the pathologist did a very interesting thing. Some of the bladder, not cancers, but the pre-cancerous conditions in bladder, they took the cancer word out of the name so that they could start watching them. You know, this is a huge issue with prostate cancer. I've had a patient who had a Gleason 3+3 cancer. 1 out of 12 biopsies positive. 20% of that one biopsy was positive. I knew the pathologist, knew him really well. He's really, really very good. Had a guy who's 65 years old. He had already had a triple bypass. I told him he was the perfect candidate for observation therapy. He slams his fist down on the desk and says, "God damn it, I'm an American. You can't tell me I have cancer and we're going to watch it." And I'm thinking, you know, I just wrote a paper where 0.5% of all men who get radical prostatectomy die as a complication of the treatment. You know, by the way, the Hopkins group 2 years ago published a wonderful paper in the Journal of Clinical Oncology, and the title was, "Should Gleason 6 prostate cancer be called cancer?" Yes, sir.
You know, if Richard Caliber won the Nobel Prize yesterday for saying that people don't often make the right choices. And you look at Steve Jobs
Yeah.
and what he did. How much of that is our problem in America?
It's a huge problem. Huge. It's actually interesting you should admit, my daughter works for him. It is a huge, huge problem that people think they know a little more than they actually know. It's a big problem for doctors. Huge. You know, in my book, that I said I wasn't going to plug, and this gets back to the Catholic conversation earlier, one of the Jesuits who taught me in high school, when he found out I was going to medical school, he said, "I just want you to remember, there are things you know, things you don't know, and things that you believe, and doctors tend to confuse what they believe with what they know." And that is so, so true in the United States. You know, we were just talking about prostate cancer. You know, Gil Welch, who I think has given this talk in the past, he actually estimates that 1.3 million American men were treated and cured for prostate cancer needlessly in the 1990s. You know, we started prostate cancer screening in the United States in 1989, and there was a study in 2009 that finally showed that prostate cancer screening might save lives. That was the first one to show that it might save lives, and it's still not definitive. We started prostate cancer screening in 1989, and the first study to ever show that any of our prostate cancer treatments saved lives were published in 1998. Yeah, so yeah, we do a lot of these things. You're absolutely correct. And our fear of cancer has driven a lot of, in my world. Yes?
So, are Americans uniquely irrational?
No. Americans are not uniquely irrational, although it does sometimes seem that we have more irrationality. There's this independent me streak in Americans, in our culture, that we haven't dealt with, and it may be, it may be the fact that we came through the communist era and that sort of stuff in the 1930s and 40s. Some of our reaction to that may actually be because of this independent streak. But there is irrationality in other countries when it comes to medicine as well. And of course, there's irrationality when it comes to politics in other countries. Yes.
So that leads to, I'll see if I can formulate my question here. Just trying to get at, clearly we don't do what we know we should do.
Mhm.
We do too much of stuff that's useless. But how much is sort of our standing in terms of how much we spend,
Yeah.
actually because we charge too much for what we do? So I guess my question is, are other countries also not doing the right thing and doing too much of the wrong thing,
Well,
but they charge less?
Interesting. I don't know the answer to your question, but I will tell you that the fact that we do so much fee for service ends up driving a lot of stuff. One of the stories that really changed my thinking about American medicine had to do with prostate cancer. In 1998, I was one of the people, when I worked for the Surgeon General, who negotiated the apology for the Tuskegee syphilis study. So I get to go to the White House and see Bill Clinton cry. And then 2 weeks later, I'm working for the federal government. I visit a major American cancer center that I will not name. And when the big guy from the government comes out, because we give so many $1 million in grants, they have to have this dog and pony show about how great their research is. And so I'm sitting there watching this presentation. It was actually pretty interesting. I'm sitting next to the marketing guy, who's just beside himself about how great he is and how great their university is. And he starts bragging to me about their business plan in prostate cancer. And he explains to me that every year they do this free screening at this mall, and when they announce 8 weeks ahead of time that they're going to do this free screening for Prostate Cancer Awareness Month, this is the bump that they get in business from their breast screening. This is the bump they get in business at their chest pain clinic because they're doing free screening. And he knows how much it would cost to get that same amount of publicity if he went to NPR or to the newspapers and bought it, but they get it for free. And when they go to their screening for that weekend, he said, of 1,000 men who roll up their sleeve and say, "Screen me," they're going to have 155 who have a positive PSA. And 10 of that 155 is business for their competitors, God bless them. 145 are going to come to them to figure out why they have a positive PSA. And they're going to charge an average of $3,000 to figure out why they have a positive PSA. And they're going to hit bingo on 40 to 45 of the 145. Bingo was his term. And of the 40 to 45 with prostate cancer, this is the number they're going to get surgery, this is the number they're going to get radiation, this is the number they're going to get freezing, which was popular in those days, and they've dropped away now. And then of the ones who they treat, this is the number who are going to have urinary incontinence. And so if we screen 1,000 guys, this is how many artificial sphincters we're going to sell and our urologists are going to implant. And then he was apologetic because Viagra had just come out, and that screws up his estimate of how many men are going to be so upset about the impotence that he doesn't know how many artificial penile implants they're going to sell. And so he's talking to me. He's talking to me, and I said, if you screen 1,000 guys, how many lives are you going to save? And he said, Doc, don't you know? He knew this. There's never been a study to show that prostate cancer screening saves lives. This is all about making money. He's honest. I met Lucifer that day. Unfortunately, this morning as I was coming down on the TV in the hotel, they had this ad for carotid and heart scanning. You don't see that in Europe. You have to pay out the fee-for-service thing, and the want to make a buck is driving lots. And I mentioned Nexium versus Prilosec earlier. When AstraZeneca had one hell of a problem with Prilosec. They were making $5 billion a year off of it, and they only had 4 years left on the patent. So they started this thing called Operation Shark Fin, which was they called it a corporate Manhattan project to find the next multi-billion-dollar drug. And what they found out was that the active ingredient in Prilosec was the left-handed enantiomer of the drug. The right-handed enantiomer was inert. Your kidneys just urinated out. And so they separated left from right, made a pill of left, did a randomized clinical trial to show that the active ingredient was equivalent to Prilosec, got it patented in the United States, got it FDA approved because it was equivalent and safe. And then they started packaging it. These marketing guys, be careful. They marketed it as a big purple pill, and they called their next multi-billion-dollar drug Nexium. And you could get it for 16 years for $180 a month, but you could get generic Prilosec for $8 a month. By the way, that's an important point. There were patients whose doctor said, rather than give you Nexium, just go buy Prilosec. And the patient would say, I want to spend the $2 extra and spend the $10 copay to get the drug worth $180 as opposed to spend $8 for the drug worth $8. And this is an American story, getting back to your point. The European Union said, we gave you a patent on that compound 18 years ago. So there was never a proprietary Nexium in Europe, nor in Canada. It was only in the United States.
Thoughts, they're past 9 o'clock, on to do good care. Come on down and talk some more. What a stimulating conversation. Oh. Thank you so much.
No problem.